Well, it's the Weird Medicine COVID-19 situation report for March 29th, 2020. I'm Dr. Steve, and I'll be your host for today. So the numbers, let's start with the numbers for this week. I'm looking at Italy, USA, and China. China being the most mature data. And we're going up to 68th day since they've been keeping records on this. And we now have 85,000 cases in the United States. New cases over the last 24 hours were 16,894. This is most likely a function of increased testing, which over the next week should be rolling out significantly. You can see that China has arithmetic increase. In other words, it's the same number every day. It's around between 100 and 150 cases every day. Ours has been spotty. Again, I think that these numbers have to do with the way that these numbers are being reported, and I think there's a big plop of data sitting on someone's desk somewhere. And these things don't always get put in a linear fashion. You can see that Italy's has calmed down somewhat in that they're no longer increasing geometrically, but looks arithmetically again, where they're increasing by the same number every day rather than the same multiplier. Here it is in graphical form. These are total cases, so these will always either go up or eventually level out. They can't go down because this is cumulative. So this is the United States. You can see we kind of tooled along doing sort of nothing for 2 months, and then boom, here we go. And here's China. Had leveled off, but now is increasing in this arithmetic sort of linear fashion again. They've relaxed some restrictions in some parts of China, and so they, when these cases pop up, they're going to need to isolate those folks and their contacts. And you can see the Italy is going up in this linear fashion, and the slope is a little less than ours. The slope here is pretty steep. This is slightly less steep. This is the epidemic curve. This is China. You can see this sort of Gaussian, or this bell-shaped curve. And this spike here had to do more with the change in the way that they classified cases so that they could include people who hadn't been tested but showed clear symptoms of a COVID-like disease, which could be influenza as well, as you know. And then this is the curve for Europe, and the white is the curve for the Americas, and it's spotty. You see how it's just spotty and not a real pretty curve just yet, because data gathering is still, I think, rather spotty. Here's new cases in detail. This is from my hand-entered data set from the WHO database. You have to pick one. So there's lots of different databases. I just picked WHO so I could be consistent. And here's Italy. You can see, look, this is actually looking more like a trend over the last 7 days. They've evened out their number of new cases. They're still getting a lot of new cases, so that the cumulative curve will go up. But this is a very nicely flattened out curve, and we'd like to see that start to decline. Here's the United States. We were flat, and then boom, boom, boom. Now this zero is most likely a lack of reporting, so really this was quite a climb. Then it was looking good there for a couple of days. We had a couple of days where we had a decline, and then an increase, and then a steep decline, and now an increase again. So probably the curve is more like that. So we'll see. We just need lots more data to smooth out these data points. So this is where we were a week ago on the left, and this is where we are today. And if you want to see which points correspond to each points, there they are. These points correspond to these points here. So you can see a significant increase in cases in the United States. Again, likely a function of increased testing and, of course, new infections. As we test more and more people, we're going to get more and more cases, and that's actually not necessarily a bad thing. We will, as the number of cases increase, what we hope to see is a decrease in the overall mortality rate of this virus, just by virtue of the numbers, so that we're getting closer to the true mortality rate. For example, if you have a disease that has 300, well, let's say 100 people have the disease and 3 of them die, that would be a 3% mortality. Well, what if there were 900 people that were asymptomatic? So now it's 1,000 people on the denominator, and that makes the mortality 0.3%, which is a big difference. My friend Daniel Stout from Stout Labs made this viewer. He's looking at lots of different data sets. And here's the address, or you can go to my Twitter, and I tweet this out every couple of days. But Stout Labs -covid-compare.netify.com. And we need to do a bit.ly for that to make it a little bit easier to get to. But these are total cases, and here we're looking at USA, Italy, Spain, and Norway, just to pick some. The USA and Italy are sort of in a race for the most number of cases per capita. So let's look at that. So we can look at deaths from these. You can see the number. These are absolute numbers. So the number of deaths in the United States, about 2,000. Italy, 10,000. Spain, 5,000. Norway, 23. And now new cases. Here's the interesting thing. You see, here's the United States. Do you see these sort of periodic dips? Here's a dip here, a dip here, and a dip here. I believe that this is a function of some reporting because they're very periodic. You can see here's another one here. That there is some bottleneck in reporting, and so this, I'm guessing, should be actually smoothed out. And then here we are, this confirmation of Italy's cases being evening out significantly in here. And case per 100,000 population, this is one way to look at it. In mine, I look at percentage of the population. The United States still has 0.036 cases per 100,000, whereas Italy has 4 cases per 100,000. All right, okie doke. So that's my friend Daniel Stout from Stout Labs. He's also a genius web designer. So let's look at some COVID-19 news. I'm rubbing my nose, which I shouldn't be doing when I'm saying that, and I got the word nose in my head. Viability on surfaces. So there was this study that showed that SARS-CoV-2, which is the virus that causes COVID-19, can survive on some surfaces for several days. Now, these were done under laboratory conditions. This was not really done as a study. Can you get this stuff from a package from Amazon? This was done to compare its viability compared to SARS-CoV, which was the original coronavirus that caused the SARS epidemic 10 years ago. Detectable does not necessarily translate to infectious in the real world, and that should say in the laboratory, not in the late. If cardboard were an important vector, we would have seen immediate global spread out of China in the first few days of the outbreak. So we have not seen that. But here's what they found, half-life on surfaces. Let me go back to this sort of 3D slide. And this is from New England Journal of Medicine, and I created these just from their data of half-life. So if you look at aerosols, what they did was they took the virus, put it in an enclosed environment, and then tested to see if they could detect viral RNA. And indeed they could. And the half-life was approximately 1 hour, which means at the end of 1 hour, half of it's gone. At the end of 2 hours, another half is gone, and so on. And so by the end of 13 hours, there would be virtually nothing left. And this does not mean that this is transmitted this way. Gravity is a factor. These things are contained in droplets that are released from the respiratory tract of infected individuals, and those droplets are subject to gravity. So they hit the air and hit anything around them and fall to the ground or fall to any surface that's in their way where they can sit for some time. Fomite transmission, which is the transmission on, say, steel, which the half-life is 6 hours. Here it is here. Someone snots in their hand and then touches a doorknob, and then you go in and touch that doorknob and then don't wash your hands before you stick your hands in your face. There is some possibility that you could contract the virus that way. But cardboard, here's the cardboard curve. It's, almost completely gone at 22 hours. And again, that's detectable, not necessarily infectable. Here's another way to look at those data, not so fancy 3D, where you can see red is cardboard, blue is steel, yellow is plastic, and green is aerosol. Again, laboratory conditions. Detectability does not equate to infectability, so that's what that was about. Okay, let's look at testing. So this is 9 days old, and they haven't updated this database yet. But you can see with total confirmed cases of COVID-19 on the x-axis and total COVID-19 tests on the y-axis, that this thing makes sort of a linear relationship, which means the more you test, the more cases you will find, right? So anybody along this sort of median line, they need to test more people, because so in Russia, they tested a lot of people but had relatively few cases. And whereas in the United States, we're along this line that says that we tested a lot of people and we had a lot of cases. So we need to test more folks so that we end up, high on this but low on the number of cases. All right. So testing is going apace. As far as the number of total tests, the countries in the top of this tier are Italy, South Korea, United States, Australia, United Kingdom. Okay? All right. Who should be tested? Right now, still not everyone needs to be tested. This is from the CDC. I think that everyone needs to be tested. This is my personal, when we have the ability to do so. But for now, when we have limited resources, we need to reserve those for the people who are the sickest. And the reason that they're not testing everyone is because most people have mild illness and they're able to recover at home, and there's not a treatment. It's not like we're going to test you and then therefore we can treat you. What testing does right now is help you to identify contacts. So when you have someone that's sick, you test them, and then you identify their contacts. If they're sick as well, but they're healthy, you don't have to necessarily test them. What you have to do is quarantine them. So, but as time goes on, and we're going to talk a little bit more about IgM testing in a minute, I would like to see lots more people get tested just to see who has been exposed to the virus. We'll talk about that in a second. This Abbott ID Now test has been approved for emergency use in the U.S. It returns results in 5 minutes. It requires their proprietary ID Now testing system, which costs about $10,000 to buy, but a lot of labs and offices already have these, and they use them now for respiratory syncytial virus, which causes croup and influenza and other things like that. This detects the presence of the virus by identifying a smaller section of the viral genome than, say, a PCR or preliminary chain reaction test does, which is the sort of gold standard right now. But it does amplify it, and then it renders it detectable. And the cost is, I looked at Fisher Scientific, that's $21.70 for 24 RSV packs, which I figure will be pretty analogous. COVID pricing wasn't available when I checked. So that's about $100 a piece. So you're going to pay $100, $200 a piece. and your insurance most likely will cover that. But you can get it back in 5 to 10 minutes, and it does tell you whether you have viral RNA in your nose. Now, I don't know the sensitivity or specificity of this test, which we talked about last time. If you're interested in understanding sensitivity and specificity, we talked about that previously, and I can talk about it again if you'd be interested in talking about it in depth. Basically, if something is a test is very sensitive, it will catch all the positives, and if it's very specific, it won't report people who it will have very few false negatives. Okay, so if you're negative, you probably don't have the disease. There is some updates on the Diamond Princess case. This was a case of a group of people who were about 4,000 people who were enclosed in an enclosed environment together for some time, and then had an outbreak on the boat, and they were quarantined to the boat, and every single person was tested, which is great because that's what we're talking about. So this is sort of a microcosm of where we are. It's artificial microcosm. There are differences between this and, say, a community, but at least it gives us some information. So you can look here that at the peak they tested 4,000 persons, and the number of patients who tested positive were 712. The number of people without symptoms that tested positive were 331. And as of today, or as of the date that we did this, which was March 23rd, there were 10 deaths. So if we want to look at the percent of people who are infected, and remember, these people were basically sealed together in a tin can on the ocean in an enclosed environment for the most part. And they were all eating off the same buffet, drinking at the same bars, and interacting with each other. So there were 4,061 people on board that ship, including crew. 712 were infected. So that gives you a 17.5% penetrance into the population on that ship. So under 20%. Mortality was 10 people out of 712, so 1.4%. And my understanding from Dr. Hopland, who we interviewed on my radio show and on the podcast, that these were primarily elderly folks who had comorbid conditions. The interesting one to me is the percent of people who were asymptomatic, which was almost half, 46.5%. So if we test everyone, let's say we test 1,000 people and they're positive because we tested them because they were symptomatic, you would think there would be another 1,000, another half, again, as many that were asymptomatic that never got tested. So the IgM tests and the IgG tests that we'll be talking about in another slide should help us to answer those questions. If you missed the interview with Dr. Arnold Hopland, we did about an hour and change with him discussing his experience of being quarantined on that ship for a couple of weeks with his wife, who was positive, and he was never positive. But you can listen to it at riotcast.com. None of the COVID-19 podcasts are behind the paywall at this point. They're all free, so you can go listen to them. Fetal and maternal risk has been an issue. I've gotten a lot of questions about that. They reviewed 38 pregnant women in China, and they also, included SARS and MERS patients in some historical cases. And there were no maternal deaths in those 38 pregnant women and no cases of intrauterine transmission. And all placentas that were tested were negative for SARS-CoV-2 by polymerase chain reaction. So that's good news. This is not like Zika. It doesn't seem to cross the placental barrier and cause any difficulty for the fetus. The risk to the fetus is the risk to the mother. And the risk to the mother appears to be low. There doesn't seem to be any specific risk to pregnant females right now. So let's look at coronavirus drug updates for today. There's a rheumatoid arthritis drug that's showing some promise. It's Tocilizumab. Golly, I knew I was going to do that. Tocilizumab. It's a monoclonal antibody that they use for rheumatoid arthritis. They gave it to 20 of the sickest patients with multi-organ failure. So you have to think, why would someone have multi-organ failure when they've got a virus that's attacking their lungs? We'll talk about that in a second. 19 of the 20 were discharged within 14 days. This was approved for use in China and trials in the United States. So Tocilizumab is marketed under the brand name Actemra, and it probably has no antiviral effect, but it's probably an immune modulator. Well, it is an immune modulator, but its probable beneficial effect is in reducing a thing called cytokine storm. So your immune response is good, but a hyperimmune response is not good. And viruses, why would a virus in your lung cause renal failure? Well, the body generates these inflammatory cells and inflammatory proteins called cytokines, and the white blood cells have this feeding frenzy, and they release these inflammatory proteins. And we see this a lot in hemorrhagic fevers like Ebola. And in Ebola, the benefit to the virus is that the bleeding that's caused by this opens up new sites for the virus to bind to. So there's a benefit to the virus to cause this bleeding. And in COVID-19, the cytokine storm causes multi-organ failure, where these inflammatory markers cause inflammation in the kidneys and maybe the liver and other places. And this Tocilizumab reduces interleukin-6, which is an inflammatory mediator. This stuff is not without adverse effects: heart failure, pancreatitis, stroke, scarring of the lungs. But this is generally seen in a few patients after long-term administration. Right now, we're talking about maybe treating these people for 4 or 5 days, maybe 7 days. So I think that the risk is minimized by the shortness of the exposure to the drug. Another one is convalescent serum. The more people that recover from SARS-CoV-2, the more people out there will have circulating antibodies against this virus, and these are neutralizing antibodies. And you can donate your plasma if you have recovered, and those antibodies can be isolated and given to ill patients. They really don't isolate the antibodies themselves necessarily. They just give the whole serum. And the problem with that is, for every one patient, you can maybe treat 2 people. So it's not very scalable. But there are labs trying to grow antiviral antibodies in bulk, and one of those is Regeneron, and they hope to have 100,000 doses of antibody, their antibody cocktail, ready by June. So that will be awesome. A lot of people have been making hay out of this hydroxychloroquine trial that was disappointing. The headlines touted some seriously disappointing results in hydroxychloroquine in a 30-patient trial in China, which showed non-significant improvement in fever reduction or disease progression. But this wasn't a great study for looking at hydroxychloroquine, to be honest with you. These patients were also on other medications, including interferon alpha, a broad-spectrum antiviral called Arbidol, and an antiretroviral combination called lopinavir, ritonavir, which is sold under the brand name of Coletra. So, if even one of the other drugs had any effect on the virus, the effect of hydroxychloroquine couldn't really be determined, because you couldn't tease these things out. So, and even the researchers themselves said the sample size was so small they couldn't have told an effect, even if there was one. When you have a disease that has a 99% recovery rate, you got to treat a lot of patients to even see any effect. So if you have 1,000, let's say 100 patients, and let's make it even crazier than that. Let's say you have 30 patients, and you treat them all with hydroxychloroquine, and they all get better. You haven't shown anything. You've shown nothing, because 99 patients out of 100 are expected to get better anyway. Hydroxychloroquine and azithromycin. This was this French preliminary trial, which was published online prior to publication. The researcher that did this is very prolific, and he He's a hoot, I'll tell you that. 15 years ago, he had a study that showed one of his postdocs probably falsified data, and instead of just withdrawing it, my understanding is that he just attacked his critics. So a lot of people are throwing shade on this study, but still an interesting study and one that needs to be replicated. That's what you do in science. If someone comes out with something incredible, you try to replicate it. This happened with cold fusion. These two researchers who were physical chemists came out with a paper that said that they demonstrated that they produced fusion at room temperatures, and people scrambled to reproduce it and never could. And that's how science works. So we need to try to replicate this study. It was important enough to warrant a further investigation. He did say that he demonstrated viral load reduction and appearance at day 6 compared to controls, and these results were reinforced by the addition of azithromycin. We will see. Okay. There is a trial currently ongoing in New York State looking at this, and there are people concerned about this prolonged QTC interval. So I keep seeing this where physicians and other people are saying, well, just hold on, don't get too excited about hydroxychloroquine because the combination can cause prolonged QTC interval. So if you don't know what that is, let me just go through that. So here is an EKG tracing. Here's a P wave, a QRS wave, and then a T wave. Okay, so PQRST. And this is the atrium contracting, and this is the ventricle. I'm making this simple. So the people out there that are electrophysiologists, I know that's what we're talking about is depolarization, repolarization. Okay, calm down. This is basically the electrical activity when the atrium of the heart contracts. And then this is the electrical activity when the ventricle retracts, and this is during relaxation when everything resets. Okay, so if this is the PQ wave and this is the T wave, then the QT interval is between these two places: the end of the T wave, the beginning of the Q wave, and this is sort of normal, and then this is prolonged. Now, who cares? Well, if you prolong this long enough so that now you get a QRS wave on top of a T wave, in other words, you're trying to depolarize at the same time you're trying to repolarize, you get a really crazy heart rhythm called torsade de pointes. Let me see what I have here. Okay, and this is what it looks like. So we get, beat, 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 R on T phenomenon, and then boom, 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 boom. And they call this torsade de pointes because it means rotating around the point. And this thing in 3D is actually rotating toward you when it is small and rotating at right angles to you when it's large. So this thing the axis is rotating around this point. And then it gets better. Boom, 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 boom. Here this person goes, and then now they go into it again. And here's another case of torsade. Okay. All right. Risk factors for torsade are advanced age, female gender, renal failure, liver failure, but the incidence of this is considered to be about 2.5 to 4 per million in people taking methadone, which can also increase the QT interval. The incidence is considered to be about 1 in a million. So I think the risk is pretty low, especially given that we're going to be treating these patients for a very short period of time with these medications. But okay, so if we're going to give them both and they're at risk, we need to put them on a monitor and do it in the hospital. There is a new study being done by the World Health Organization. They're sponsoring it. It's called Solidarity. Clinicians who have a positive case log onto the WHO website, and they let them know the criteria of the patient and then what medications they have on hand. And they will then randomize them to one of 5 groups depending on what they've got. So they can't randomize them to something they don't have available. So one is hydroxychloroquine, one is lopinavir, ritonavir. These are these HIV drugs. And then lopinavir, ritonavir, and with interferon, which is this inflammatory modulator, and then Remdesivir, which we've talked about. We'll talk a little bit about these. The lopinavir, ritonavir is sold as Coletra. Mentioned it a couple slides back. It prevents viral reproduction. There was one study in NEJM that showed no benefit, but it was, again, a small study. Needs to be done on a much larger group of patients. There may still be a beneficial effect, or maybe a subclass of patients that do better with this stuff. Remdesivir is from Gilead Labs. They developed it originally for Ebola, but didn't do anything, but they had some effect in vitro and animal studies in the MERS, the Middle East Respiratory Syndrome, which is also caused by a coronavirus. And this stuff presumably blocks RNA replication during the reproductive cycle. And it was given to a severely ill patient in the United States under this compassionate use program, and he began to recover the next day. This is a single person, so this is basically anecdotal evidence. And doesn't tell us very much, but I'm very excited to see what those studies show, and we should have results. Remdesivir is in phase 3 testing, meaning that there's thousands of people being tested with it right now, and we should have some data in the next few weeks. Here's the silly person of the week, this quote-unquote influencer. Can we be done with influencers, please? He reportedly hospitalized with coronavirus. It's not funny. I shouldn't be laughing, but it's just, come on. After licking a toilet, he probably didn't get it from the toilet, but if he's licking toilets for his YouTube channel, he's probably also was not socially distancing the way he should. So just lesson learned. I just want to show you a quick video on the effects of a mobile and connected society versus the public good on potential viral spread. Let's take a listen.
We wanted to see the true footprint social gatherings like spring break beach crowds could really have on our society in the face of a global pandemic. To do so, we started with the big picture, powering our engine with billions of anonymized location data points from mobile devices across the globe. Using tectonics, we can then zoom in on specific regions. Here, we focus specifically on just one beach in Fort Lauderdale during the month of March. Again, each of these data points shown on the map corresponds to a unique mobile device active on a given day. You can see clearly that device activity spikes during the 2-week stretch of early to mid-March corresponding with spring break. No surprise. Now, using an analysis called a spider query, we can actually track movement of these devices over the remaining weeks of March, seeing where these devices went after spring breakers left the beach. As we zoom further and further out, it becomes clear just how massive the potential impact just one single beach gathering can have in spreading this virus across our nation. It can be hard for us to realize sometimes just how connected our world really is, until the data tells the stories that...
Things happening this week, data, more data. There are drug trials going on right now. As we've mentioned, the vaccine is still in phase 1 testing. I'm advocating to skip phase 2, which is a smaller upswing, and go straight to phase 3. That would cut out about 3 to 4 months out of this. If you remember vaccine phases, phase 1 is about 40 to 100 patients that you test to make sure that the vaccine doesn't kill them. And then phase 2 is a slightly larger cohort where you look at is it effective, which takes time, and has it shown any increase in adverse effects. And then phase 3 is where you give it to thousands of people and watch it for all the same things. And then if you can justify its release, you release it to the market. And then phase 4 studies or aftermarket studies. Cutting out phase 2 in an emergency, I think, is reasonable, given that vaccine technology is pretty robust and mature. We'll see if they listen to me. We'll have increased testing this week, so we should see a spike in numbers, but hopefully a decrease in the percentage of deaths, therefore, because we're catching more asymptomatic and mild cases. And the antibody test kits are still supposed to hit the market this week or next. These are IgM tests that look for recent exposure, which will be positive after 4 days, or current exposure, as long as the patient has been infected for at least 4 days, and IgG, which will show resolving exposure and more remote exposures. The tests are supposed to be 96 to something percent sensitive and specific at about 92%, which means that there will be about 8% of people that are deemed negative by this actually may have antibodies. So it's not a perfect test, but hopefully will allow us to identify those people, particularly when it's positive with IgG, that could maybe go back to work and get this lockdown moving a little bit. All right. So stay healthy. Isolate yourselves still for now. Wash your hands. Cough into your elbow, but then don't touch elbows with people. Let's not touch each other at all. Can we? I'm with a lot of people in advocating that we get rid of the handshake altogether. Check out our Twitter at Weird Medicine and podcast at riotcast.com/weirdmedicine. And check out our SiriusXM show on Faction Talk, either on demand or at 8 p.m. on Sundays. 8 p.m. Eastern on Saturdays and 5 p.m. Eastern on Sundays. And then on demand. And on demand, we'll have some things that never aired as well. If I have a little 15-minute interview with someone, we'll just stick it up there on demand. And go to the cdc.gov for further information. And the WHO website also has some interesting information on there as well. And just stay healthy, everybody. If you have questions, email me at weirdmedicine@riotcast.com. And I promise these things will get better as time goes on. I hope you got something out of this, and we'll see you next week for the next edition of the COVID-19 SITREP.